Okay, we get started. Okay. Hello, I think we can get started. I can see a number of people coming into the meeting. I wish to take this opportunity to welcome everybody for this meeting. Good morning and good afternoon to you all. Thank you so much for always turning up in numbers for this very important meeting to the working group. I'd like to welcome you once again. And for any new participants, definitely we have to introduce ourselves. I am Mariam Nabukenya Wamala, and together with Gabriela Hunter, we are the co-chairs of the RBM working group. And I would like to take this opportunity to let you know that we have this call interpreted and you have to select the interpretation, whether in English, French, or Portuguese. Please select the language for interpretation at the bottom right-hand corner of the screen. You can see that globe, click on it, and you'll be able to select the language. Other than that, our secretariat will send you all the slides in the 3 languages that we have them recorded in, and the report of the event will be done on email. I would also like to take this opportunity to let you know that we have 2 major presentations today. One from Dr. Abdusalam Nohu of the World Health Organization Global Malaria Program, and Mike Fosso, our colleague who is on the Secretariat Committee. As you listen to these presentations, please keep adding your questions into the chat and we'll be able to attend to them in time. At this very particular moment, I am thrilled to be welcoming Dr. Abdusalam Nohu from the World Health Organization, who is the head of the Unit of Strategic Information for Response at the WHO in Geneva for the Global Malaria Program. And just a little bit about Dr. Nohu. He is also a visiting professor of epidemiology at the University of Oxford. That's very important to us, Dr. Nohu. Thank you for joining to give us a brief. We also are aware that you have served as a director of the Nairobi program of KEMRI, and also a chair of the board of directors of the Kenya National Council for Population and Development. Dr. Nohu, of course, we have met. Thank you so much for accepting to be with us today to present to us the World Malaria Report. The floor is yours.
Thank you. I have been told, yeah, okay, good. I'm happy to be with the SBC working group today, and happy to present what I consider to be a summary of the World Malaria Report 2022. I'll do so in the next 10 minutes or so. I wanted to, before I present the slides, just highlight the fact that the World Malaria Report is a collective effort. The WHO takes the lead, but it's really a collective effort to which many people contribute, over 200 individuals, 25 or so partners. And I'm sure some of you on this call may have directly or indirectly contributed to the report, and I thank you for it. Next slide, please. Last year's report, first of all, each year, at least in the recent series, we try and focus on a specific thematic issue that's of importance globally. And we've had the Crossroads series where we highlighted that progress was stalling, the launch of the HPHI, the refocusing on the vulnerable groups, 2 series around COVID, and the latest series around the 4 key thematic areas that are shown on this slide: response, risk, resilience, and research. Next slide, please. There are a number of things that one could highlight in the report around each of these thematic areas. We had one key message for each thematic area, and I have trimmed quite a lot of the slides, so I'll just give you the highlights. And the first key message related to the response was the global, regional, and the national response that, particularly during the COVID-19 pandemic, that ensured that we collectively averted what would have been the projected worst-case scenario at the beginning of the pandemic, which was going back to the 2000 levels of incidence and mortality rates. Thankfully, with the help across the board and heroic efforts by countries, the worst-case scenario was averted. That said, the COVID-19 pandemic, as many of you would acknowledge, still led to significant disruptions in essential malaria services, and leading to an increase in cases and an increase in mortality in 2020 and 2021 compared to 2019. However, one of the things we highlighted in the report was that despite the increases, the response managed to maintain, to mitigate against further increases in the burden of malaria in 2021 relative to 2020, which in itself is a really impressive outcome given the challenges that we are dealing with globally. Next slide, please. Just to highlight one of the key interventions that we rely on, ITNs, 3/4 of the planned ITNs were distributed. And in fact, the last 2 years collectively have been some of countries have reported some of the largest distributions of ITNs on record, which essentially, again, highlights how impressive the response was despite the significant challenges. With regard to seasonal malaria chemoprevention, the number of children who are receiving this intervention, particularly in the Sahelian areas, doubled in 2021 compared to the levels we were in 2019, largely attributable to significant increases in coverage in Nigeria. Next slide, please. Just before I move on to the next message, these results of efforts at maintaining essential services also applied to case management, as we have seen in the trends of RDTs and ACT distributions. The second key message was related to risks, and particularly in the African region, where we are seeing convergence of threats, not just the COVID-19 pandemic, which is global, but specific humanitarian crises in a number of countries, particularly in some of the moderate and high transmission countries, the chronic health system challenges which we're beginning now to grapple with around restricted funding. As you know, there's a significant gap in the next cycle of the global fund funding, which will lead to significant problems in terms of how we maintain essential services. Biological threats, in particular, the emergence of SST resistance and invasive species in the African region. Next slide, please. In terms of where we are on the GTS milestones and targets, we are way off, about 48% off track for incidence of malaria. And next slide, please. Just to also say 48% off track for mortality, even though we are on track for the elimination targets and the prevention of reintroduction. One of the big challenges, which I've just mentioned, was that despite the ability globally to sustain some of the funding for malaria, which in itself is really commendable, we still have a significant gap. We have more than 50% gap in investment. Next slide, please. A particular focus area for the World Malaria Report 2022 was not just the biological threats we're facing with regards to interventions, but some of the behavioral and operational and issues related to interventions by focusing on the ITN effectiveness. And this graph essentially tries to compare an ideal ITN, which doesn't suffer from loss of physical integrity over 3 years, has bioavailability over a 3-year period is used optimally, was retained optimally, which is the top red line you see there, versus what happens when you start accounting for a number of these biological, behavioral, and operational challenges, where if you look at the purple line, you see a significant gap between the ideal and what is close to the reality when it comes to IT use. One of the things I would like to highlight, which is of relevance perhaps to the SBC working group, is that a number of these things could be adjusted, particularly when it comes to retention and use through behavioral, social behavioral interventions. Next slide, please. The risks are multifaceted. I have mentioned quite a few of them, and I'm not going to go into the detail, but also to highlight that a major risk we face is not just related to the interventions and our ability to put them in the communities, but also our ability to understand what's going on in those communities and the whole issue of weak surveillance systems. Next slide, please. The third message was related to resilience and essentially highlighted in the face of all of these challenges, how national malaria programs and their partners demonstrated resilience through a very difficult period, whether it's through targeted strategies or innovative ways of responding during a crisis. However, they're still grappling with a number of these important challenges that put a particular strain on their ability to adapt to crises such as the COVID-19 pandemic, or emerging ones such as biological threats and the situation with the funding. Next slide, please. A number of things contributed to this resilience. Paramount is the country leadership. Without that, there would be no meaningful resilience, but also not to forget the global coordination around the COVID-19 response and the various work streams that we all participated in, and to highlight the role the funders have played, particularly the COVID-19 response mechanism, which actually created lots of flexibilities in the way countries respond to the pandemic and the challenges of the pandemic. Next slide, please. As WHO, one of our key roles is to provide normative guidance, and we've tried to be as responsive as we can during this process. And as you can see, we have several documents that have come out. There is a strategy to respond to ACTs, the initiative to stop anopheles event-size spread, the framework for response to malaria in urban areas, a new way of assessing surveillance systems, but also a much more interactive way of disseminating these policies and recommendations through the Magic app, which essentially now all of this content is available in an app, mobile app that you can download whether you have iOS or Android. Next slide, please. The last message is, and the prominent message of the report was around research and development. To highlight the role research and development has played in actually getting us the progress we've seen, whether this is in vector control space or in diagnostics or treatment or chemoprevention, and looking ahead some of the new products and technologies that may enhance our ability again to respond to the malaria threat. Next slide, please. As WHO, we've been busy working through preferred product characteristics so that we can catalyze the market in terms of what the priority products are and how best to respond to those priorities. And many of these PPCs are now online and they cut across all the key intervention areas. Next slide, please. Just before I end, to say that in highlighting all the research and development aspects, in the last report, we worked with a lot of PDPs, and this include MMV, IVCC, FIND, UNITAID, and others who have contributed to that particular piece of work. I will end by saying that all of this information is really a summary of a summary, and all the resources that you may need are available on the link that have been provided, and you can download an app. It's called the Wild Malaria Report, the Wild Malaria Toolkit, which contains the report, the guidance, and the terminologies on any of your mobile devices. Thank you very much.
Thank you so much for your insightful presentation, Dr. Noor. These 2022 World Malaria Report highlights crucial understands in our efforts to get back on track to achieve WHO 2030 targets. Thank you for raising so many key and important messages today, all of which are relevant to our work here and SBC. Thank you as well for the resources at the end of your presentation. Just to introduce myself, my name is Mike Toso. I'm a senior program officer at Johns Hopkins CCP, and I'm serving currently as one of this working group steering committee members. Today, I'll be presenting on some of the SBC implications of the World Malaria Report that Dr. Noor just took us through. Slide. So the World Malaria Report 2022 data points a picture of largely stalled progress. Preventive behaviors like ITN use are high, but access remains a key constraint. Because you look at these three bullets, I want to reemphasize that point again. Net use among those with access is quite high, and the key constraint remains access to those nets. So when you're looking at numbers like 38%, 54, 47, those are household coverage, population access. But if you look within those who have access, use tends to be quite high. So a take-home point on this slide is that preventive behaviors like net use are really quite high, and the key constraint remains that we need to get access. We need to increase access. So what are the SBC implications of this slide? First, there are places where net use is low, and in those cases, use SBC to increase net use. In fact, as this World Malaria Report points out, although clear social and behavior change communication strategies exist, these critical interventions remain under-resourced and greater investment is required. As a second point, WHO modeling also suggests use is close to access, and with greater gains, and that the greater gains could be made if nets lasted longer. So we need to maintain levels of use and increase care of nets if you want to get beyond the 2 to 3 years of efficacy, sort of close that gap between 3-year to 3-year mass distributions. So collectively, as practitioners, we need to increase the proportion of households who tie up their nets when not in use. Slide. Just to reiterate the importance of human behavior in SBC for ITNs, let's break down some more of the insights of the World Malaria Report. This year's report cites a number of factors that influence ITN ownership, retention, and use. Our working group should take note that some of the factors cited in the report are behavioral or managed at the household level, which concerns us the most. In terms of equitable allocation, we need to make sure that people have nets, and equitable allocation of ITNs at the local level is crucial. This comes down to planning net distribution campaigns, but also accurate and thorough household registration during campaigns. Getting people to that registration is a key household behavior. In terms of retention, the report states that the median ITN lifespan is 1.9 years. So we need to make sure that the nets people obtain last as long as possible. To support that goal, household net behaviors should be prioritized. Finally, in terms of net use, people have to consistently use their nets. Most of the numbers in this report on net use the night before the survey. We really need to focus on is consistent net use. And as we said earlier, while use among those with access is generally high, where there is room to grow, this report suggests looking at sociodemographic factors, gender, and areas of malaria risk as important factors. So in summary, use SBC to increase ITN use. It works. However, it's chronically underfunded. Maximize ITN protection by increasing the portion of households that tie up their nets when it's not in use. Important message here is that preventing nets from being damaged is far more effective than repairing them once they've been damaged. So the emphasis should be on tying up and hanging up nets when they're not in use, not on net care and repair, or repair, that is. Slide. So this is a slide that Dr. Noor showed, and we just want to bring it back up here. It is an important way of describing different scenarios and how nets can be effective relative to use of nets, the provision of nets, and how long the nets last. The 2022 World Malaria Report includes this graph that illustrates net effectiveness over 3 years. As you can see, in the perfect and near perfect scenarios, which are the red, orange, and green lines, ITNs don't last 3 years. In realistic scenarios, which are the dark green, blue, pink, and purple, ITNs last no more than 2 years. That leaves a year gap between the end of the average ITN lifespan and the next distribution, assuming distributions are taking place every 3 years. So we have evidence that SBC can extend a net's lifespan by as much as a year. We know that tying a net up when it's not in use is the most effective care behavior. So the SBC implications are clear. Again, maximize net protection by encouraging the household behavior of tying nets up when they're not in use. Slide. World Malaria Report 2022 data also paints a picture. Sorry. As I was mentioned before, it paints a picture of stalled progress. This is true as well of ANC attendance, which remains below target. And it's concerning to see that IPTP doses delivered are far below the number of ANC visits made, indicating that there are clear gaps in provision of this essential preventive medicine. So what are the SBC implications? In terms of ANC, priority focus should be encouraging pregnant women to attend ANC as early in their pregnancy as possible, as this is a prerequisite to obtaining maximum coverage over the course of their pregnancy. Moreover, SBC can help overcome structural and access barriers. Well, in the ideal situation is that ANC services expand to be accessible as possible, even to the most remote communities. This is not always the reality. As such, there's a role for community structures to be mobilized by SBC to provide support for women to get to ANC multiple times throughout their pregnancy. Slide. In terms of treatment, comparing baseline and the latest surveys, there was little change in prevalence of fever within the 2 weeks preceding the surveys or in treatment seeking for fever. Prompt and appropriate care seeking for children under 5 is one of the most important means of reducing malaria mortality, and it isn't increasing. This behavior has not changed much. And from an SBC perspective, perhaps it's inappropriate to begin shining light on the social and structural factors that need to be addressed for care seeking to increase. It's clear that the current focus on individuals doesn't appear to be enough to yield results. There has been a greater focus on service provider behavior change in recent years. It is encouraging to see that provider adherence to diagnosis and treatment guidelines is increasing. That said, these data show that there is a lot of room for growth there as well. Increasing treatment seeking from community health workers where this is available, and building trust between patients and community and facility workers alike should be prioritized. This is particularly important in an environment where the rollout of medical interventions is scaling up quickly. With an increased emphasis on preventive medicine, optimizing impact with limited resources will be difficult. When resources are scarce, SBC usually suffers first. But even in the context of greater preventive medicines, SBC does have a role to play. From an SBC perspective, communicating the safety and efficacy of new drugs will be important. With the SMC age groups expanding, there could be confusion as different locations decide different age of children that are eligible for SMC. So what is the role of SBC to support SMC service delivery partners to keep SMC eligibility clear, maintain trust in the intervention, and high uptake of all doses and rounds of SMC? In terms of the new drug resistance strategy, it's a strategy that has 4 pillars. In that second pillar, there are a number of sub-activities, one of which concerns SBC practitioners. This is optimize and better regulate the use of diagnosis and therapeutics to limit drug pressure through preemptive measures. And one of the suggested sub-activities within that is empower patients, healthcare workers, and other stakeholders to make informed decisions and provide appropriate treatment. Moving on to the relatively emerging emerging issue of invasive anopheles stephensi. This will necessitate adaptations in SBC. What approaches are the most effective in urban environments in terms of reach and uptake of interventions like ITNs? Countries might consider stratifying their urban and rural approaches even more than in the past. And is it appropriate to begin allocating more resources to mass media in urban areas in these scenarios? What kind of framing would raise perceived risk and severity among urban and peri-urban residents? Only the differences between Plasmodium falciparum and Plasmodium vivax may need to be communicated, as many communities, particularly in West Africa, will not have been exposed to Plasmodium vivax, with a severity and treatment that differ from the Plasmodium falciparum that they may have been used to. In terms of the new vaccine, requires 4 doses at prescribed intervals and has a limited efficacy, at least when compared to other vaccines currently available. Households must still practice malaria prevention behaviors. SBC programming is needed to promote the uptake of the vaccine schedule, emphasize its safety, and also balance that with the need to continue sleeping under nets and taking other malaria preventive behaviors. I think the takeaway from this last slide should be that awareness of what it means to rely more heavily on medicine-based prevention and control. As we scale up the use of existing medicine and introduce new drugs, a new vaccine, it will be increasingly important to communicate with health workers and households alike. What are these drugs? What do they do? Why is adherence to the regimen so important? Without increasingly detailed and nuanced discussion, trust in providers may erode. That is exactly the opposite of what is needed. So in this new era, perhaps the most important SBC emphasis will be on building and increasing trust between community members and facility providers. Thank you so much for the opportunity to present these malaria SBC implications. I'll hand the floor back to Gabrielle Hunter.
Thank you so much, Dr. Noor and Mike. It's really an honor to have both of you speaking back to back to our working group about the importance of the latest trends coming out in the World Malaria Report and how the SBC cadre of professionals working in malaria can do their part to address it. So with that, we will go ahead and open up the question and answer session for both of our speakers. If you have a question, please put it in the chat box now, and we will start addressing them one by one. Our first question is for Dr. Noor. Dr. Noor, just following up on what Mike has just walked us through in terms of social behavior change and communication activities, will you talk a bit more about the role of strategic communication in reaching the 2030 WHO targets that you see as the priorities?
I think Mike actually has done an excellent job of trying to tease out the key areas in which social behavioral change communication could actually serve an important role. I am not a communications person at all, so I'm assuming the question is related to what our general view is here, or my personal view is as to the role of the strategic communication, as opposed to any sense that I'm an expert in that space. You know, the only thing I reflect on whenever I think about SBCC is who does it, how it's done, and who sustains it. And at the end of the day, the true impact really is at the community level. And you haven't communicated well if you haven't engendered a behavior change. And one of the things I haven't really seen done properly is the role of the people who are supposed to really be the change agents for community behavioral change or individual behavioral change. And this is essentially people who are in the affected communities and villages. What is their role in a much more deliberate way? How do they support the change from a communications perspective? If they're not on board, nothing will happen. And I'm not sure there are many, and again, I'm coming in as a non-expert. Ask me something to do with malaria strategic information and I can give you a coherent answer. Anything to do with communication and other things, probably not. But just to say that, you know, one of the areas that I would like to see personally is the affected people really being not just recipients of information, but generators of useful information and useful ways of communicating to change what's happening on the ground.
Thank you so much, Dr. Noor. And certainly do not sell yourself short in terms of your expertise. I think that our group really appreciates hearing the perspective that you have about the importance of not only of SBC, but as you mentioned, that true buy-in and true engagement from communities and people affected. And so we do find that quite helpful to hear. And as Miriam also mentioned in the chat, we wish to recruit you as an SBC champion. So thank you. And we're thrilled to have you here. Let me move into a next question for Mike. Mike, can you discuss a little about the sociodemographic factors that you see affecting net use and any new evidence available?
Sure thing. I think one of the best resources that you can go to is itnuse.org. If you go here, you can find detailed information about who's using nets among those with access. But if you scroll down further, you can look at a section called ITN use by age, gender. And one of the graphs shows you in households with enough nets or in houses without enough nets, are male or female members being privileged or are being prioritized, or are children being prioritized, or pregnant women being prioritized. So I think even as we see high use among those with access, even among those with access, there may be not exactly enough nets in the household. And in those scenarios, prioritizing pregnant women and children under 5 is really important. And we have the data on this itnuse.org page. It goes back a decade in a lot of cases, and it's summarizing data from the MIS, DHS, and NICS surveys. So in terms of what we know about demographic use and gaps in prioritization, I think that's a fantastic resource.
Thanks, Mike. A few more questions around nets, so let's just stick with that theme to start. So again, for Mike, this question is from Claudia. Is there an example of a place where the net tie-up messages has been successfully used? And then as a follow-up question to others on the call, she's asking for a link to these materials and messages if they're available. But Mike, can you handle the first part of that question, please?
Sure. It is something that's been going on actually as far back as 2010, when Senegal was the first country to adopt a universal coverage distribution mode. There have been attempts in that country. The Trois Toutes campaign was an SBC campaign rolled out at the same time as the distribution. And folding up nets, tying them up, transforming them from rectangular to circular, whatever way it would take to keep the net used and out of reach was used. So we have examples of those materials. And I don't have other specific examples on hand, but we'd be happy to go out and find.
Thanks, Mike. And to that, I might add also some of there's been a wide use of net tie-up messaging of late going out in multiple countries, especially following a successful pilot of that intervention in Nigeria a few years ago, where there was evidence to show that the exposure to the campaign was to a campaign about net tying up was linked to that behavior, which was also linked to longer net longevity. So we can certainly share that. And so then again, one more question again around nets is a question related to one of the points you made on the slide, Mike, around how the World Malaria Report emphasizes ensuring maximize equitable allocation of ITNs. This is a question for both presenters. What are some ways that we can ensure better equity in allocation of ITNs? Maybe Mike, you could start and with any SBC angles to that, and then from Dr. Noor, we could hear thoughts from WHO more generally.
Thanks, Gabrielle. I think in terms of equity, this is something that's very much on the minds of those who are procuring and distributing mosquito nets, both in mass and through targeted channels. We know that mass distributions and targeted channels like ANC or giving nets to children's immunization programs, they're reaching different groups in different ways. And I think this mix of distribution channels between mass distribution as well as focused does achieve a certain level of equity. However, when you look at countries that are nearing nearing elimination, or they may have different pockets of transmission. We are going to find increasingly heterogeneous populations, and there are going to be vulnerable, hard to reach groups that may need to be prioritized in terms of equity. So just a real quick example of things that are working and things to consider going forward.
For me, there's ample evidence that mass campaigns are potentially some of the most equitable ways of distributing interventions. And the evidence from ITN suggests that there is a considerable level of equity that's been achieved. My concern has been trying to distinguish between equality and equity. And very often, the way we've looked at the ITN coverage issue is there parity between ITN ownership when you compare the poorest and the richest households or the wealthiest households. And that, to me, is not a particularly effective way of looking at the problem, because the need is also concentrated in those who are socioeconomically most vulnerable. And so what happens is we take aggregate country data, we look at, we lump urban and rural together. Even if we separate those, the need isn't across the board. And so we are really poor at identifying the need, particularly when we do not have the resources to reach everyone. And so I think we need to challenge ourselves to start thinking more seriously about equity and not just equality, and to be more deliberate about targeting those communities that actually contribute most disproportionately to the burden of disease. And very often we think the best way to look at this is geographic, but when you have an intervention distributed through mass campaigns, the quickest thing that you mitigate against is that geographic disparity. What you do not clearly understand is those people who are socioeconomically marginalized. And by that I mean their problem isn't that they are not close to where bed nets have been distributed. For one reason or another, they are consistently missed from that access equation. And so how do you understand that? We don't have good studies to actually point at those types of populations. When you start looking at them, they're the same ones who miss out on vaccines, the same ones who miss out on other health interventions, and therefore the children most at risk of dying, or the mothers most at risk of dying. And I think we do mention equity and equality all the time, and some of the people who defend our current approach to targeting ITNs very often mix equality and equity, but the two are different. I would suggest that when you really scratch the surface, we're not doing very well on the equity side of things. And that requires making hard decisions, including not putting interventions where their public health impact is unlikely to be big, especially when you're dealing with an important gap in places where you know the impact will be considerable.
Thank you so much, Dr. Noor. That's a really important insight for our group to take forward on equity. Thank you. We have time for just a couple more questions. And I want to field at least one question that has come in around the malaria vaccine. There's been a few of those. So this is a question for Mike from Wani. And this question asks about, just having in mind that that the malaria vaccine, the value of the malaria vaccine is primarily around reducing child mortality due to malaria, even though vaccine efficacy, perhaps to prevent infection, is lower than one would have anticipated. So how can SBC messaging be articulated to handle this this nuance? I see, Dr. Noor, you're unmuted. I don't know if you wanted to also share some thoughts.
I don't have a specific answer to how SBCC can handle this, but I just wanted to point out that we have to be careful when, for one reason or another, for whatever the reason, you start taking very hard positions on interventions. It's better to step back a little bit, look at the evidence carefully, and start thinking about whether something really has a role or not. And unfortunately, right from the time the RTSS was recommended, there were already two camps around those who are for it and those who think it has poor relative cost effectiveness given the cost and the efficacy. But if you step back from all the noise and you went to an African community and you told them, we have an intervention X, it's likely to reduce hospitalizations by 40%. It's likely to reduce all-cause mortality by 10%. Don't give it a name. Don't call it a bednet. Don't call it a vaccine. Don't call it anything. Just call it X. What will be the response of those people in terms of how much they would want that intervention? And I'll suggest the response would be overwhelmingly positive. Then the cost issue comes up. And the cost issue is legitimate, but it should never be the overriding decision maker, particularly when we are collectively relying on largely imperfect prevention tools. And the gains really in the cumulative effect of those tools, and not necessarily trying to push one down on the basis of cost, when in many ways, when you start looking at the pathway to impact, when you look at the efficacy, it's not dissimilar to a bednet, but when you look at the pathway to impact, it's very dissimilar to bednets, and potentially a lot more active in the way it's accepted and potentially used, and the potential impact, because you don't have to change people's behaviors once they have the vaccine in their body. So there are a lot of things that we need to look at before we take very hard positions on any of these interventions, including how positive we are about existing interventions because they are scalable, they are at low cost, without reflecting on the fact that the baseline efficacy that led to their recommendation isn't the operational efficacy that we have today, as has been clearly demonstrated in the graphic that I presented, and Mike also did a good job of explaining the different scenarios. So I'll stop at that, but that's something I want everyone to reflect on so that you don't get caught up in a particular box when it comes to discussing these interventions.
Thank you, Dr. Noor. I think that's actually really, really helpful and novel framing for the way we think about the work that we do in generally, not only for the situation of the malaria vaccine. And it's helpful to be reminded of how much we all fall into maybe boxes of the way we think about things just based on the label that we put on them. So if you call it a vaccine, people have this automatic expectation of certain levels of prevention or efficacy, but reframing instead the way we think about the benefits of our interventions can really help us bring everyone on board. And I just want to thank you so much for sharing that way of thinking with our group. I think it's always helpful for us to be shaken up a little bit to think about things differently.
Thank you.
And with that, we've run up to the end of our time for the question and answer session, although I see so many great questions that have come in through the chat. And I will ask Dr. Noor and Mike, if you do have some time, if you wouldn't mind answering a few of them in the chat box itself, that would be really helpful so that our colleagues can have some answers as well. Let me move on then to the next section of our call today. We wanted to share some updates with the group around our upcoming annual meeting. And for this, I will pass the floor to Elizabeth, who will get us started, and then Ibrahima, who will share some updates in French. Elizabeth?
Thank you, Gabriela. And hello, everyone. My name is Elizabeth Chiende. I'm a member of the SBC Working Group Steering Committee. I'm based in Zambia, and I'm very excited to announce that the 10th annual meeting of the SBC Working Group will be held in person this time, and it will be held November 7th, 8th, and 9th, and it's going to be held in Abidjan, Cote d'Ivoire. Please, 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 this is exciting. Let's keep focused and let's make sure that we follow through the instructions as well as the information coming through. So the annual meeting, as you all may be aware, is a very important opportunity for all malaria professionals, particularly SBC professionals worldwide. They are able to share experiences in malaria SBC. We're able to also participate in skills building sessions, discuss many emerging issues such as the one that has just been discussed around the malaria report. And it also helps us set the working group priorities for the coming year. So this is critical. Just to share a few highlights on the agenda for the 2023 annual meeting, please note opening remarks will be made by the Ministry of Health in Cote d'Ivoire, and we have other speeches as well as other opening remarks and talks from RBM partnerships. We have the PMI, the SBC working group, and many more. In addition to that, there's a planned welcome reception, which will take place, and all are invited. There's going to be plenary and poster sessions. You will note that a call for abstracts has already been sent out. Also, we have available skills building workshops where people will be able to learn and exchange ideas on different thematic areas. And additionally, we have work stream updates and work sessions, plus many more. So because we have people from different parts of the world, interpretation will be made available in English, French, as well as Portuguese. More information about the annual general meeting can be found on our website. The website, as you know, will be posted in the chat. And also to stay up to date with many other meeting announcements, please join the Social Behavior Change Working Group emailing list. The link is equally in the chat. So registration for this important meeting will soon open. Please stay glued and ensure that you register. Opening dates will be announced through our mailing list. Please note, there will be limited spaces, so keep an eye on your mailing list for registration. The registration fee is $250, and this includes entrance to the 3-day meeting. It includes lunch, as well as tea breaks. Kindly note, there is going to be limited sponsorships available, mainly for national malaria programs, and applications for this will open in late May and will be announced through our listserv, as well as our website, sorry. So, just before I hand over to our next speaker, I wanted to know and invite those who are interested in supporting the steering committee and secretariat in planning for this year's annual meeting. You're welcome to join, and there'll be a form that will be shared in the chat. Planning committees will include one for abstract review. We will also have a committee that will look at participant engagement, including fun activities, icebreakers, networking, etc. And we have a committee that focuses on skills building and planning. And the final committee will look at the evening reception planning. So thank you very much for your time and for your attention. And I look forward to seeing you in Abidjan this November. Please don't forget to visit our meeting website for more information. I now want to hand over to Ibrahim, who will be taking us through track 1 of the annual meeting abstracts, and Ibrahim will speak in French. Ibrahim, over to you.
Thank you very much, Elizabeth. Hello, everyone. My name is Ibrahima Sano, and I am a member of the steering committee. Today, I am going to talk about the process of developing abstracts for the 2023 annual meeting. The abstracts are due by May 31st. They will be accepted in English, French, and Portuguese. The submission guide, the templates, and all the tips are available at the website that you already have. This year, we will have two possibilities for submissions. The first one will be the update of national malaria control programs. And the second idea, or the second submission form, sorry, will be through sharing experiences of the SBC in the coordination and integration of malaria, community health workers, and data for decision making. Now, I would like to give you some tips on how to submit your abstract. And for example, the National Malaria Control Program to share updates. You could see a submission guide on the address that you see on the screen. And the idea is to know, is the information well written? Is the information flowing logically? Are the ideas clearly formulated? Are there mistakes, grammar or spelling mistakes? For the context, we need to describe the context, the background, describe the behavior objectives, and list the determinants and barriers to behaviors if known. We will also need to do a clear and sufficient description of programs, activities, or research methods, in a description of the robustness of the approach. We need to address the determinants and barriers to desired social and behavioral change outlined in the program objectives. And we do have questions. Did the authors use a behavior change model? Did they use a framework or a theory to inform to the approach? If it is a research, are the methods of data collection and analysis described? The information that we will need to include in the presentation are results to date. How does the National Malaria Program Control monitor results? Are the results expected or unexpected clearly described? Are measures of frequency, dose, or intensity of exposure to the interventions described? Are monitoring and evaluation data presented? What does the data show to be a success? If we speak about challenges, lessons learned, and conclusions, we need to include relevant reflections on recent experience of the program lessons learned, the impact of the work and considerations on how the program will continue to move forward, especially knowing the difficulties encountered in the field. Are the conclusions supported by data or results presented? Are the findings relevant to other contexts? What are the next steps or different activities, CSC, for the National Malaria Control Program based on this recent experience? This is what I wanted to give you as an update for this year. Thank you. And if you have questions, please do not hesitate to contact the Secretariat. I will now turn it over to Gabrielle. Thank you.
Thank you, Ibrahima. I will now share some of the tips for the track 2 themes of the track 2 abstracts. In track 2, anyone is welcome to submit an abstract from any organization. We are particularly interested in abstracts that might touch on one of the following 3 themes. The first theme of interest is coordination and integration of malaria SBC. And here we're interested in how malaria SBC programs coordinate with other partners in malaria or other health areas, or integrate into programs with other health areas. The second theme of interest is community health workers. This is a group of workers that is increasingly receiving more attention at this moment in time, and we wanted to have a theme specifically dedicated to them. So here we're interested in malaria SBC programs that are working through community health workers or supporting them in different ways. And our third theme for this year's abstracts is data for decision making. This is the use of data to make targeted, informed, and strategic decisions about malaria SBC programming. Next slide. We're always interested in receiving high quality abstracts. What would make a track 2 abstract of high quality? Very similar recommendations for quality as what Ibrahima just described for track 1. So I won't repeat them all. I would just like to highlight that one thing that matters a lot is that each section of the abstract is clearly linked to the following section. So for example, in the description of the SBC intervention, we would like to know how the program is addressing the problems that were described in the section before in the problem description. And on the next slide, when it comes to discussing your results, we would like to see results and data that came directly out of the data collection and analysis methods that were described in the prior section. And finally, the conclusion. Do the results directly support the conclusions that are stated? Please try not to overstate the findings of the conclusions or state conclusions that are not linked to the results that you've just presented. So this is what I wanted to highlight in terms of tips to make a very strong track 2 abstract. In addition to everything that Ibrahima just shared for track 1, the same applies. Next slide, please. Some best practices for abstract submission for both tracks is to request feedback from your colleagues, do a final check, and be brief. Make sure that every sentence in the abstract is providing essential information. If it's not essential, then maybe it's not needed. Next slide, please. Please be on the lookout for a request to submit proposals for skills building workshops. This will come separately from the abstracts. Some of the details are here for skills building, but much more will come out soon when we make the call for these proposals. Next slide, please. We do want to hear from all of you, our membership, as we plan for the annual meeting. So we will share now a link to a survey in the chat box. We will also share this survey out over our listserv. We have some questions for you about what you would like to see in plenary presentations, as well as what kinds of skills building sessions you would like to see. So please do take the time to fill out the survey. It will help us quite a lot. And finally, we will close with one last announcement for the membership. Next slide. Our next general call will be on July 13th, and I'm really excited to announce that we will dedicate that call to SBC for the Anopheles stevensii response. We've been hearing about this invasive mosquito for some time now, and think it would be very informative for all of us to think about how SBC can support the efforts to respond. So we will be able to share some new guidance that has come out around this topic. So please mark your calendars and join us on July 13th. Next slide. A reminder, these are the best ways to stay in touch with us at the working group. And I'd just like to thank you all for participating today. And again, to our excellent presenters, Dr. Noor and Mike, and all of you for the questions you shared with them. Have an excellent rest of your day. Thank you.